Hello and welcome to today's Center for Healthcare Strategies webinar made possible by the Robert Wood Johnson Foundation on 618 Initiative State Assessment Activities, Technical Assistance Opportunities, and Examples. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session at the end of today's presentation. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I will now turn the webinar over to Shilpa Patel, Senior Program Officer at the Center for Healthcare Strategies.
Thank you, Travis. Hi, everybody, and welcome again to the webinar. My name is Shilpa Patel, and I'm a Senior Program Officer at CHCS, and I will be the moderator of this very informative webinar. This webinar will explore the range of assessment-focused activities that 618 states may consider as they implement prevention priorities. During the course of the webinar, speakers will provide an overview of the 618 framework and a general description of types of measures for states to consider in their work, provide an overview of Medicaid quality measurement efforts and state technical assistance opportunities, and discuss potential assessment-related technical assistance and measurement examples for 618 states. We will conclude the webinar with a moderated question and answer session. I will now like to welcome and introduce our webinar speakers. From the CDC, we are joined by Naomi Chen Bowers, a Senior Service Fellow from the Population Health and Healthcare Office, and Jessica Gomez, a Health Scientist from the Office of Smoking and Health. From the Center for Medicaid and CHIP Services, we will have a presentation from Deirdre Stockman, the Technical Director for Quality Improvement. Our final presentation will be from Lacey Hartman, a Senior Fellow at the State Health Assistance Data Access Center, or SHADAC. I will now turn it over to Naomi and Jessica, who will provide information on the 618 assessment framework and progress measures for 618 states.
Good morning, everyone. This is Naomi. Thanks so much for joining us. If we can move to the next slide. This is the 618 strategic framework. The boxes on the far left, engage partners, provide resources, and implement interventions, are the key activities that states engage in as part of 618. This leads to the next set of outcomes, such as improved access, improved quality, and increased utilization. We in 618, as a team, identify and disseminate promising practices around activities and getting to outcomes to support states in reaching the 618's two goals of supporting cross-sector partnerships and contributing to improved health and cost outcomes. Next slide. As you may have seen at the convening, this is the theory of change. Today, we'll share examples of how states measure things within the different boxes of the theory of change. Next slide. These are some categories of key measures that roll up under the theory of change: process and implementation, utilization, and health and cost outcomes. Next slide. These are some things to consider when you are thinking about who monitors the indicators you might be interested in and how you might access their data. For example, Medicaid could use claims and encounter data and quality metrics. Health agencies might use survey data such as BRFIS. If you are a state who is doing tobacco activities, you might consider, say, trying to access quitline data. Some states have developed data use agreements to share data between agencies. Next slide, please. These are some considerations as you think through the types of outcomes you are trying to demonstrate and what metrics would help you demonstrate those outcomes. Also, think about what data is available. So, for example, as you, let's say, have conversations between Medicaid and public health around what's available, you might ask yourselves questions such as, do you have baseline data? Do you have follow-up data? Can you compare trends pre and post 618 work? Do you have comparison groups? And judging from past states' experience, it really varies. So every state's in a different place with these questions, but it's a way to get started. So Also, another consideration is that key decision makers might be interested in utilization and outcome measures. And a key piece of context might be how many people need services. I'll pause to let you briefly look at some of the examples that are listed on this slide. Next slide, please. These are examples of potential indicators. You might consider using Medicaid core measures, which Deirdre will speak more to, or other MCO quality data. You might consider using claims or encounter data and use billing codes to identify relevant claims. You might consider tracking services used or averted. You might also consider using hospital or emergency department discharge data where relevant. You might consider using health survey data to measure changes in outcomes. Some states, and we'll see this in further examples, have done special surveys such as MCO surveys to understand current coverage practices. Next slide, please. It's important to present and share results both internally and externally. Internally, this will help you understand what is or is not working. You might share findings with partners and decision makers such as policy officials. Externally, when you share your results, it helps you highlight your work to other states and stakeholders who are interested in, let's say, Medicaid and public health reform. Next slide, please. These are some examples of how states tracked things related to implementation. So there are three examples given here. One, the first is MCO benefit coverage surveys. So that might be a state going to their different MCOs and understanding what the current state of coverage is, both what's in writing and what the MCOs actually do in practice. Another example is tracking media impressions, or what happens as a result of outreach to Medicaid enrollees and also providers through mass media or other sorts of literature distribution. Another example is provider behavior. So in this specific case, that could be a CAP-HEDIS measure NQF-27, seeing whether or not physicians and medical providers actually talk to their patients about cessation. Next slide, please. This is one example of how states might track utilization. A tobacco state might track quitline call volume specifically from Medicaid enrollees. Next slide, please. Some examples, additional examples of utilization measures for asthma might be the asthma medication ratio, which is NQF 1800. Possibly use of asthma action plans. So again, thinking about the extent to which providers are working with patients to improve their asthma maintenance. Next slide, please. Some examples of health outcome measures might be smoking prevalence as measured on BRFIS and adult tobacco use surveys. States might, for example, consider adding a question on Medicaid status to their surveys. Another example could be percent of patients with controlled asthma. Next slide, please. This visual puts it all together. Deirdre will return to this later, but I wanted to introduce this as a way to think about all these different sorts of indicators, how they fit together, for you as you consider in your specific context what's most relevant to your stakeholders and your work and your activities. It's kind of an overall, what we might call a dashboard or a one-pager for you to just see these things at a glance. I'd like to hand it off now to Jessica Gomez, my colleague from the Office of Smoking and Health at the CDC, for some tobacco-specific thoughts on measurement. And we'll keep this slide up for your reference. Jessica.
Thanks, Naomi. Can you hear me?
Yes, we can.
Perfect. So as I'm going through this theory of change visual that Naomi is sharing, I'm going to put more a tobacco lens on it and share some example outcomes as well as some example data sources for each. So three major data sources that I'll discuss as I'm talking about outcomes include Medicaid claims data, surveillance data, and quitline data. Depending on your state, you may also want to, you may also have some other data collection systems in place. So you may want to consider conducting a quick scan to get a snapshot of existing data sources and opportunities to collect data. So let's say at the activity level, if your state's efforts are focused on health systems change to increase provider screenings or assistance to quit and referrals, and maybe you're also working on expanding barrier-free coverage for Medicaid recipients, what are some outcome indicators you may want to consider? For intermediate outcomes, some key ones to consider include whether you're seeing an increase in screenings, assistance or advisement to quit, an increase in referrals, increase in utilization of covered cessation treatment, and potentially also an increase in use of the quitline. Potential data sources you can use to assess an increase in screenings, assistance to quit and referrals include state-level surveys like BRFIS or the adult tobacco surveys. Some states do collect this via their state-level surveys. For example, Vermont includes these measures in their ATS. If these measures are not being currently collected in your state, you can check if there are opportunities to add questions to ask about them. You may also be able to capture some of this data through the National Quality Forum. To measure an increase in utilization, probably the most accurate data source would be to analyze Medicaid claims data. Several states have done this, and in Colorado, after they approved a statewide protocol to expand the scope of the practice of pharmacists to include counseling and dispensing of cessation medications, the state tobacco control program worked very closely with their Medicaid agency to analyze claims data, and they were able to show that utilization of cessation pharmacy benefits increased 60% over baseline after the introduction of the benefits. After the introduction of the changes. You can also work with your state quitline to examine whether there was, as Naomi was mentioning, an increase in calls to the quitline from Medicaid recipients. If you conducted a campaign to raise awareness of benefits or to promote utilization, you may also want to work with your state quitline. There might be opportunities to add a question related to your campaign or your awareness efforts. For example, Florida did this after they implemented a campaign, and they worked with quitline vendors to add measures to assess whether there was an increase in awareness after the campaign was implemented. If you want to measure increased awareness among providers, depending on your resources, you may be able to conduct a post-campaign survey of a sample of providers. New York City did this after an awareness campaign in order to measure reach of their efforts and whether they saw observed differences in whether an advisement to quit and whether or not they were referred to the quitline and other services. Looking more at health outcomes and more longer-term outcomes, the key ones you want to measure are an increase in quit attempts, increase in successful and sustained quits, decreases in tobacco use prevalence, and whether or not there's reductions in costs, as Naomi was mentioning earlier, and ultimately reductions in tobacco-related morbidity and mortality, although that certainly takes more time. For assessing increased quit attempts and sustained quits and changes in tobacco use prevalence, you can capture this through any of your state-level surveys that capture tobacco measures. BRFIS collects this. You just have to keep in mind that there should be, ideally you want the question that asks about Medicaid, like about insurance coverage, to assess whether or not, specifically for Medicaid recipients, if there's been an increase in quit attempts and sustained quits. If your state quitline collects information, particularly if they conduct follow-up surveys, you may also work with them on assessing sustained quits among Medicaid recipients through that mechanism as well. So I believe, those are some examples to consider as you're looking at your theory of change, and some measures and indicators you may want to consider along the different types of outcomes. Just to quickly wrap things up, some key takeaways. Use your logic model framework to really think through and prioritize your measures of success, and look for opportunities across your logic model and your theory of change to look for opportunities to collect data across the various sources to provide a better picture of your program. Vermont did a really good job of doing this, where they were able to use data across their logic model to try to triangulate not only the work that they did, but what that led to, whether it led to increased screenings, utilization, increased awareness, and ultimately quit attempts and reductions in prevalence. Work closely with your state Medicaid agency. This really facilitates evaluation planning and data collection. There are many data sources already readily available that you may be able to either work from, or you can leverage some of the work that's already taking place in your state with other programs. So maybe conducting a quick scan of what's already available could help. Finally, our office, the CDC Office on Smoking and Health, has a key outcome indicator guide focused on cessation that includes a lot of good resources for indicators as well as data sources. And I will include a link to that in the chat box, but I believe it's also being disseminated with some of the materials that will be shared on guidance. And if there are any questions, we're happy to answer those at the end. My colleague Xu Wang has also joined us. She's done quite a bit of work assessing utilization among Medicaid recipients and can certainly speak a bit to that. Thanks. And I believe I will go ahead and hand it over to the next presenter now.
Thank you, Naomi and Jessica. We will now hear from Deirdre Stockman, who will provide information on quality measurement in Medicaid CHIP and opportunities for alignment with 618 activities.
Great, thank you so much, Shilpa. And good afternoon or good morning to everyone. The purpose of my section today is to give you an overview of the Medicaid and CHIP Quality Measurement and Improvement Program, which is based on the Child and Adult Core Healthcare Quality Measures, or the core sets as we call them more familiarly. This may be new for some of you and a refresher for others. I'll try to make sure to highlight some new content for those of you who may be expert in the core sets. And then I'll zero in on how you can integrate the quality reporting your state may already be doing on your Medicaid population related to the 618 conditions into your evaluation and impact assessment work that Naomi and Jessica have just been discussing. And finally, I'll highlight some of the technical assistance support related to quality measurement and improvement that's available to all of you from CMS to supplement and go along with the 618 technical assistance. On the next slide, we almost always start with this slide because it gives a picture of our overall quality measurement and improvement program here at Medicaid and CHIP. It's based on the foundation of the upper left circle of quality measurement. So we support states in collecting and reporting a core set of quality measures to CMS. Then on the right, we conduct analyses of those metrics to identify opportunities for improvement and to assess the progress states are making on the key indicators in the core sets. And finally, at the bottom, and this is my focus here, is we work to provide states, support to states to use the measures to drive improvement in care and health outcomes. We're currently working hard to scale up our analytic and quality improvement capacity and support here at CMS, and we hope you'll hear more about that soon in all of your states. And as we're doing that, we're always thinking about how we can most efficiently and effectively partner to complement existing efforts focused on improving outcomes in Medicaid and CHIP, such as 618. On the next slide, what are the core sets? There are two sets of metrics that are currently voluntarily reported by states to CMS. The measures are organized into several domains, including primary care access and preventive care, care of acute and chronic conditions, and behavioral health care. I'm calling out those among others because that's where most of the 618 related measures reside. And of course, many measures in our core sets could fit in multiple domains. We use the domains as sort of an organizing principle to help keep a moderately long list manageable. The core sets are tools states can use to monitor and improve quality of care provided to their Medicaid and CHIP beneficiaries. Of course, the core sets are not the end-all be-all. States can and very much do, of course, use other measures as needed to assess and track performance on aspects of care important to them. As all of you know, there's great variation from state to state in the population served by Medicaid and CHIP and their healthcare needs and the conditions that they may be facing. So states are always free to select and use additional measures beyond the core sets. The core sets consist of a set of measures that have been identified by our stakeholders as fairly core or of importance to most Medicaid programs and to allow for a little bit of comparability and tracking across states over time. You've also likely heard of the Medicaid and CHIP scorecard. At this time, a subset of the core sets make up the state health system performance pillar of the scorecard, but I'm really talking about our broader core sets today. On the next slide, you'll see an overview of kind of the core set basics. So the child core set came first in 2010. It was created by CHIPRA, the Children's Health Insurance Program Reauthorization Act of 2009. And so states have recently completed the 9th year of voluntary reporting on the child core set. The adult core set came a few years later. It was created by the Affordable Care Act. And you'll see states have been reporting that for about 6 years now. You'll see on the slide also that, as I mentioned, reporting is currently voluntary. We have 51 states voluntarily reporting on at least one child core measure in our most recent publicly reported year, fiscal year 2017, and 45 states reporting at least one adult core measure. And you'll see, the median number of measures states report is 17 or 18, depending on the core set. As I alluded to just briefly, there's an annual stakeholder-based review process for the core sets. Just last week, our contractor facilitated the annual core set review meeting for this year, where the group considered and made recommendations of measures to add or remove to the core sets for fiscal year 2020. So stay tuned for updates to the core set. Usually CMS releases them by the end of the year for the year following. It's a little bit confusing, the reporting years. You do not need to get hung up on that at the moment. So on the next slide, what do we do with the data that states report to us? We publicly release data on measures that 25 or more states report to us in adherence with the technical specification. So when we have relatively comparable data from 25 or more states, we make those data publicly available in a variety of different ways and formats. So I want to briefly, and this might be new even to some of you who are experts in Medicaid quality measurement, I want to briefly make sure you're aware of some of the analytic and data products that are available to all of you on Medicaid.gov and where you can see your state and other states' performance on core set measures. So on this slide is the sort of landing page for the Medicaid state overviews on Medicaid.gov. And you can click on your state or any other state you're curious about and get a lot of information about the Medicaid and CHIP programs in that state, not limited to quality. The bullets here summarize just some of the things: eligibility and enrollment, recent state plan amendments, other various kind of facts about the program, and quality of care is one of the sections. If you go to the next slide, you can see a snapshot of the quality section on the state profiles. And I chose a state that is not participating in round 3 of 618, somewhat randomly, but one that did include one of the 618 measures here on this sort of screenshot I could get. So you get a sense of how many of the publicly reported measures the state is reporting, and then you can see a few of the kind of tiles there are for show the performance of the state on those measures and vis-a-vis the national medians and quartiles. And so on the farthest right there, for example, is a little tile on the hypertension, the blood pressure measure. And you can see there where, in this case, Wisconsin measures up with the other states. On the next slide is a not very interesting snapshot, but that's just literally what it looks like on data.medicaid.gov. For all of you epidemiologists and data people out there, you can access all of the data that are publicly reported on the core measures and do some of your own analysis or your own comparison to your heart's content. So on the next slide, I wanted to summarize, we've already alluded to a number of these measures, but the Medicaid and CHIP adult and core set measures that are aligned with 618 focus areas. And you can see in this table that hopefully isn't being cut off. It's cut off a little bit at the bottom of my screen. But we have measures in the core sets that align with just about all of the 6 conditions in 6 and 18, with the exception of antibiotic control over use. We don't have a measure for that currently in the core sets. But you'll see we have 3 related to asthma control, and some of those have been mentioned. I'll talk a little bit more about those later. For tobacco use, as you've heard, we have the NQF 27, Medical Assistance with Smoking and Tobacco Use Cessation, which is based on the CAP survey about whether beneficiaries report that their doctor advised them on smoking cessation and assisted them or provided assistance or referral to various strategies to support cessation. We don't have a perfect measure. There really isn't one out there yet on diabetes prevention or pre-diabetes. I understand there are some kind of under development right now. We have some roughly related measures of adult body mass index assessment for both children and adults. I know we're mostly focused on adults. I do want to mention for those of you diabetes-focused folks on the phone who may not focus only on prevention, there are also 3 diabetes management measures, not quite related to 618, but just for your information in the core sets. We have a very closely aligned measure on controlling high blood pressure, which is pretty consistent and used across a number of different measure sets, and also what I sometimes call a bad outcome measure, which is the heart failure admission rate for which is related in part, not only, of course, to blood pressure control. And while not a focus, I don't think really this year did include our contraceptive care measures related to preventing unintended pregnancy. So on the next slide, the next 2 slides are just briefly a few more data products that we produce in our chart packs every year, again, on those measures where 25 or more states report. We create maps that look like this, so you can see how states measure up in a geographic arrangement, which I think a lot of us find very interesting and helpful to get a little bit of a context, especially for something like any admission rate. And this one is the asthma and younger adults admission rate. This is a measure that lower is better. So you want it to be very low, and the median you can see there is just 6 inpatient admissions per 100,000 enrollee months. So that is pretty low and pretty good, but what you can see in the map is there's a lot of variation, and that can be really helpful to states to get a sense of where, you know, how they compare to whatever states you find as peers. This can be a helpful way of benchmarking and setting goals or targets for how you want, especially a measure like this when ultimately you want it to be 0, but you're trying to figure out what is a reasonable target to set for yourself. These maps can be really helpful. And there's another one on the next page I won't spend time on, but that's the controlling high blood pressure slide. So now just a few more slides. Wanted to come back to what Naomi brought up a little bit earlier. And I added a couple more details on this version that are in red. And again, coming back to the asthma example. So here is how you might integrate core set measures into your dashboard and the kinds of things that you're tracking at the state level. In this example for asthma, certainly you can do this with core set and other related metrics for any of the conditions you are all focusing on. And kind of what this lays out are things that we think, and you can take this, you can modify it, you can sort of do whatever you want with this idea if you think it would be helpful to you. But we thought that in many cases we hear from states, you know, it's helpful to have a kind of at-a-glance dashboard that we can share with our leadership, that we can share with our partners, our potential collaborators, that kind of summarizes, here's what we're doing, here are the activities in blue that we think are going to have an impact on this condition and this population that we're focused on. Here in yellow are the intermediate outcomes, the things that we would expect to see ideally within about a year to indicate whether or not those activities, those things in blue that we're doing are having an impact. And then green are the ultimate outcomes that, you know, the the goal that we're all going for, and usually there's even a little bit more of a lag. You're not going to see that usually in a year, maybe a couple of years out. So in the case of asthma, you can look at utilization of services like Jessica and Naomi both mentioned. Jessica in terms of tobacco cessation. For asthma, it could be emergency department, avoidable emergency department utilization for asthma. It could be delivery of home visits if that's something you're focused on for asthma. Those are usually things that you can count. And if your theory of change is that if we do more of these, we're going to get to a different outcome, then you want them to go up. And if your theory of change is if we do more of this, we're going to decrease emergency visits, obviously you want that to go down. Quality measures also can fit in that bucket, such as the asthma medication ratio, which again is somewhat of a process measure. We think that, and we know, of course, there's good data to support that if beneficiaries or patients or individuals are have the right balance between controller and rescue medications, and they're not overly reliant on rescue medications, they're less likely to have flare-ups, to end up in the emergency room or admitted for other reasons. Which then leads to outcomes, which could be something like a quality measure, like the hospital admission rate, but it can also be a more population level measure or surveillance measure that your state is interested in. Maybe it's days of school missed or days of work missed or other things that can be affected by uncontrolled asthma in this case. So moving on quickly to my last couple of slides, I just want to finish up with some information on the technical assistance that's available from CMS to help states drive quality improvement, as indicated at least in part by core set measures. So here, as it says, the goal of our quality improvement support to states is to provide states and their quality improvement partners. So when I say states, of course, from the CMS perspective, I'm thinking about state Medicaid agencies, and when I say partners, I'm thinking about all of the public health agencies, education, anybody in a state who is interested in improving outcomes for Medicaid and CHIP beneficiaries can be a quality improvement partner for Medicaid and CHIP agencies. And so our goal is to provide all of those state teams with the information, tools, and support you need to improve care and health outcomes as demonstrated by core set measures. We have technical assistance, and you'll start to hear about some newer opportunities helping to build quality improvement skills and capacity, develop quality improvement projects, and implement and scale and spread what you find out works, including things that you're doing through 618. If you're doing a pilot or working with a couple of health plans and having some good outcomes and you want a little support and to spread it beyond one or a couple of health plans, that's something we can help with, and a few different ways that we do that. And on my next slide, second to last, I want to make sure that you all know about a very new, just a few weeks old, training opportunity that is available to all of you for free. We have licenses for the Institute for Healthcare Improvement's Quality Improvement Open School. We've identified a core set of 7 courses that we're calling the Medicaid and CHIP Core Quality Improvement courses. If you want to complete all of them, you can get a certificate, but you don't have to complete any particular amount or really in any time. There's a lot of flexibility, but a number of really excellent, tried and true, well-tested courses for quality around how to do quality improvement, from crafting aim statements to developing driver diagrams and monitoring data to see if the changes you're making are improvements. So please, if that sounds like something that's of interest to you, check it out at ihi.org/MAC, Medicaid and CHIP, MAC quality, for more information. And we really encourage you as 618 teams to maybe take, if this sounds interesting to you, take it as a group, do a lunch and learn, think about your project or a particular activity that you're doing for 618, and you could probably get more out of the experience if you do that. So I will end now, and on the last slide, there are just a few links that will be made available to you, as well as how to get technical assistance on core measure collection and reporting. That's the MAC Quality TA at cms.hhs.gov mailbox. So if you kind of have questions about how do we collect these measures, or our state isn't reporting them and we need help, that's where you go for quality improvement, MAC Quality Improvement at mathematica.npr.com. But there's no wrong door. If you email the wrong address, we'll get you to the right people if you are interested in working with us. So thank you so much. I will hand it over to the next.
Thank you, Deirdre. I will now turn the webinar over to Lacey Hartman from SHADAC, who will present technical assistance and measurement examples from the 618 initiative.
Great, thanks so much, Shilpa. As she said, my name is Lacey Hartman. I'm a Senior Research Fellow at the State Health Access Data Assistance Center. We are a small bipartisan health policy shop located in the School of Public Health at the University of Minnesota. We do a lot of work focused on helping states and others use data, evaluation, and measurement to inform policy and operational decision making. Next slide. I just wanted to start by talking a little bit about the high-level types of TA that we can and have provided to the 618 teens. One of the things we've done quite frequently, and I'll provide a couple examples of this, are environmental scans looking for data and benchmarks. In general, we can help states think through what kinds of data sources, benchmarks, measures might be available by doing a scan of the literature, both gray and peer-reviewed, and also using some of the knowledge that we have about what other states and jurisdictions have done. We're also available for more general kind of ad hoc analytic assistance. So we're really happy to take a look at preliminary results of analyses that you've done, propose ideas for sensitivity analyses that might be helpful, think through what kind of statistical methods might make the most sense. We also have staff that are expert SAS and data programmers, and so we're always happy to review and help troubleshoot code depending on what kind of analysis you're working on. We can also provide help with data visualizations and really thinking about how you want to target your dissemination and the way that you're graphically displaying information for different audiences. And I'm going to talk a little bit about that for a specific example related to creating a dashboard to track diabetes prevention efforts. Next slide, please. So Nevada was interested in developing a dashboard to take a look at progress related to their diabetes prevention and in some cases diabetes care efforts. And they were interested in getting examples of how other states and localities have approached this kind of work. So we conducted a pretty broad scan for all public-facing dashboards that were available online that had some relationship to diabetes prevention. And one of the first things that we did was pull together a compendium of the specific measures and also the data sources that fed into those measures that were represented across those dashboards. And all the resources I'm going to talk about today, including this one, are available on the Resource Center. But in this case, the compendium also includes links to all of the dashboards that were reviewed, which can be helpful to just kind of get a sense for you know, the kinds of things we were looking at when we were pulling this together. The other piece of this resource is sort of a visualization dashboard 101. So looking across the examples in our scan, we wanted to highlight what we consider to be sort of best practices in the way that data was organized and visualized, particularly with regard to tracking progress over time. And one of the key takeaways, and it's kind of illustrated on the little excerpt we provided here, is just how important it is to provide context for the data that you present, either by showing trends, if that's possible, or to provide some kind of comparison point, be it a national average, another state that's similar to you, things like that, just to give sense for how the performance that you're focusing on compares to others. Next slide. I also wanted to touch on an example of another targeted environmental scan that we did, and Deirdre talked a lot about performance improvement projects, and I know that on the webinar last month that was talking about how to engage MCOs in 618 work, there was a fair amount of talk about performance improvement projects and how they can be, you know, a helpful way to forward 618 objectives. So information about performance improvement projects that MCOs undertake is typically included in what are called external quality review organization reports. And so what we did was we scanned for all publicly available reports that had some relationship to a 618 intervention. And what we found were primarily those related to asthma, smoking cessation, and diabetes prevention. And so the resource that's available online has information about each intervention and how it was structured, what measures were being tracked, any information that was cited in the report about barriers. So for example, whether there were problems with provider resources or getting incentives properly aligned. And then when it was available, if there was reporting on sort of at a high level what the overall outcome of the performance improvement program was, you know, whether it was positive, mixed, et cetera. Next slide. And this slide lays out a resource that's also available that we created for DC. So they were looking for examples of benchmarks and comparison points for the measures that they were thinking about tracking for one of their 618 interventions, and those are the measures listed on the slide. So what we did was we, kind of similar to the EQRO example and the diabetes dashboard example, is we did a pretty broad scan looking for benchmarks if they were available. So if it was possible to get a measure of sort of best performance on a particular outcome, or if that wasn't available, to provide a range of comparison points. So maybe the national average, how similar states were performing, things like that. And the research that's available online, and this is something that we can also do for other measures if it's of interest, is we were really careful to pull together pretty detailed information about how the benchmarks were constructed in terms of measure specifications and data sources, just to make sure that, you know, when you're selecting a benchmark, you're making an apples to apples comparison. This resource also provides sort of a helpful overview of approaches to setting benchmarks. So, for example, there's kind of two high-level approaches. One might be to set a benchmark where you're comparing performance against a particular level. So maybe your goal is to get everybody up to the 90th percentile on a given measure. On the other hand, that may not be feasible, and what you're really interested in is tracking people's improvement over time. So you might take a look at how an organization or a provider or whatever, how their performance changed after a year in the intervention compared to the baseline. And this document also provides some sort of high-level considerations for selecting benchmarks and when it might be more appropriate to look at the improvement versus comparison approach. Next slide. And now I'm going to shift gears actually kind of dramatically and talk a little bit about improving antibiotic use and some of the measurement strategies that are available there. And CDC, as those of you who are working on this intervention, is available to provide a lot of really great detailed technical assistance on this topic. But I just wanted to talk pretty briefly today about some of the measurement approaches that are available that states can consider, particularly for interventions that are focused on outpatient settings. Next slide. So this slide lays out 3 HEDIS measures that are relevant to improving antibiotic use. You know, Deirdre talked through a lot of the great measures that align with 618 in the Medicaid core data sets. But there are some HEDIS measures as well that focus on preventing improving the use of antibiotics. The first 2 measures on this slide focus on conditions where antibiotics really should almost never be prescribed. So we're looking at acute bronchitis and upper respiratory infections. And so these measures assess the percentage of cases where the patient is diagnosed with one of these conditions and then not prescribed an antibiotic. The third focuses on a condition where antibiotics are more commonly overprescribed, not necessarily that they're never warranted, but takes a look at, in cases where patients had pharyngitis, the extent to which they were also tested for strep. And so for all 3 of these measures, a higher rate is better. And if you want to go to the next slide, And I'll just speak to this really quickly. There are also 2 other approaches beyond HEDIS that states can think about. One is the mitigate metric, and there's a really great detailed online resource on the 618 Resource Center that provides information both about the mitigate intervention more broadly, and also the measure. The mitigate measure is pretty similar to the first 2 HEDIS measures that we talked about, and that the goal here is really 0 prescriptions, so they're focusing on antibiotic, never respiratory conditions. The choosing wisely measure is fairly similar. The big difference here is that because of concerns about diagnostic shifting under mitigate, and this would be a case where docs may code someone as having bacterial sinusitis in order to sort of justify an antibiotic prescription. They have included sinusitis as one of the conditions to flag, and so in this case, the goal is not actually 0. In this case, doctors are considered to be performing well if their prescription rates are about 10 to 20%. And I believe I've gone a little bit over, so with that, I will wrap up and turn it back to Shilpa. Thank you.
Thank you, Lacey. I would now like to open up the webinar for questions to all of our speakers at this time. As a reminder, please use the chat feature to submit questions. We received a question for Deirdre in the interim. So Deirdre, do you have any advice to states to develop and execute assessment plans, especially in their efforts to report some of the intermediate outcomes you had indicated, especially around kind of real-time or short-term data?
I can try to answer that, and also curious to hear what Lacey thinks. I think she noted a few of these. So I think in terms of getting kind of more real-time feedback about whether your activities are leading to a change, working, with your Medicaid counterparts, or I know there are Medicaid and public health counterparts on the phone today, working together to look at Medicaid utilization data or service claims is probably, if your state is able to get those on a fairly regular monthly basis, ideally maybe quarterly, is usually the quickest. Well, I shouldn't say the quickest, is a faster way to get data on a large population. But then the other thing is, if part of your project is a little bit more in the quality improvement sphere, or if part of your approach is to work with a small provider, a few providers, a provider group, a health plan, then you can sometimes even get more rapid feedback kind of less formally through that setting. If you're kind of implementing some changes and asking at the provider or plan level if they're seeing differences on a more rapid basis. Does that get to the question? If not, please put more in the Q&A box. I can't see anything in the Q&A box, so I'm going to have to rely on Shilpa to tell me if anything else is coming through.
That was great, Deirdre, actually, thank you. Lacey, would you add anything to what Deirdre had said?
No, I don't think so. I think that was a really comprehensive overview. Thanks.
Great, thank you. Our next question is for our CDC colleagues. How can states determine whether process or outcome measures are the most effective to assess 618 activities?
Is there a preference for Naomi versus Jessica taking that?
If you want to start, Naomi.
My hunch is that it really depends on, number one, your activity, and number two, what your decision makers need, and number three, what sort of decision you're asking them to make. So obviously, if your activity is something around like promotion of new coverage or new benefits to Medicaid enrollees, then the most direct measure of what you're doing is media impressions or things related to your actual activity. But I do also realize that the end game and what a lot of policymakers and decision makers often are interested in is really, did you move the needle on health outcomes or cost outcomes? So I think referring to what some other speakers said, you may not be able to measure that immediately, but it's worth having that in mind and worth at least starting the discussion with your Medicaid colleagues around what's available, whether you can measure that, or how maybe, as Deirdre was just asking about, monthly or quarterly reports, just to understand how it works and what you have. Those are some initial thoughts. Jessica, did you have anything to add?
Yeah, I agree with everything you just said, Naomi. I think the only other, just also considering, ideally you should be including and measuring both, but you should also consider the stage of where you are with your work and whether or not it's more appropriate to focus at, depending on what your stakeholders are interested in and where your current focus is, whether you want to focus more on what you're doing and more on the process, and as time allows and when it's appropriate, because with short-term measures, you're likely going to be able to measure those probably within a year or so of implementing your work. But with your intermediate and your longer term, you're just going to have to wait a little longer to be able to assess those, possibly 2 to 3 years or more, depending on what specifically you're measuring. So also considering where you are and what stage your program is at and what stage of implementation you're at. So I think that's it. And again, just to what Naomi was saying, it's just also thinking about what's of interest to your stakeholder and what's going to help inform decision-making for your program.
This is Naomi. I had a bit of a follow-up question for Deirdre and Jessica, and that is, have states ever done some sort of staged approach where right now they do process and then later on they measure more of the intermediate and longer-term outcomes? Any thoughts on that?
This is Deirdre. I think the short answer is yes. I think that's actually what probably most states do, but sometimes those longer-term outcomes get lost or forgotten about because what's easier to measure in the short term is process. And I think this is exactly, all of these questions are fantastic and exactly kind of to the point of where we propose that dashboard, which lists out activities, intermediate and longer term outcomes, so that which can be helpful as a communication tool to say, look, here's where we're trying to go, but we're not going to have those results for 2 or 3 years. But here are the numbers, here are the indicators that will give us a sense of whether we're moving towards that outcome that we all want in a shorter time frame. And those are those intermediate, usually more process type measures. So generally, I think states do look mostly at process measures because they're easier to collect and they have the data available, at least on the Medicaid claims-based or administrative-based measures front. But usually the intent or the desire is to have more outcome indicators because that, like you said, Naomi, is what everyone really wants to see the needle moving on, usually.
Yeah, and this is Jessica, and I agree with that. Most states usually will start off with measuring their process, looking at qualitative factors around like coverage change or policy change, and then, again, they will move on and measure some of the outcomes.
And if I could just add, there's nothing wrong. We often say outcome measures are the ultimate and the goal because it's what we care most about moving the needle on, but that's not to disparage process measures. Process measures are fantastic because they give us signals sooner, right? Because we don't really want to wait 3 years to find out if all of your activities that you're doing for 618 have an impact. We would love to have some kind of indication sooner that they're moving us in the right direction, and that's where process metrics can be really helpful, and if you have them in a broader framework, even better.
Great, thank you, everybody. Our next question is for Lacey, actually. Are there recommendations you have for specific data sets that are easy kind of to link or either share between Medicaid and public health?
That's a great question. I mean, I think that it's really a matter of which data sets tend to be housed in both places and then setting up arrangements to share or link. You know, surveys like BRFIS are typically located in public health departments, whereas Medicaid claims data are obviously housed in Medicaid. I guess the general lesson I would give is that if you're looking to share data, particularly if you want to set up some kind of ongoing data flow, to give yourself plenty of time and just know that it can be, you know, it can be a time-consuming and complicated process to get those kinds of data use arrangements, but it's definitely very doable. And we certainly have examples and best practices to share if that's something that states are embarking on right now.
This is Deirdre. If I could just piggyback on that, completely agree. And if you are looking at some data linkage or opportunities between public health and Medicaid, want to encourage you, to the extent that it's reasonable and efficient and makes sense, think about, think broadly. Some states have had a lot of success taking a kind of more comprehensive approach and saying, look, what are the various data sources that we are housing in our different components? And let's establish a use agreement for multiple of them, rather than a series of one-offs that then have to constantly be amended or updated or changed. So to Lacey's point, that it takes some time to get them established, but can be really very, very fruitful for both public health and Medicaid to better understand the impact of their programs and also better target additional opportunities for, target additional improvements. It makes sense to try to get as much in there as you can.
Great. Well, I wanted to just thank our speakers again, Naomi, Jessica, Deirdre, and Lacey, as well as all of our attendees for your participation in the webinar and your thoughtful questions. I also wanted to thank our colleague, Sana Hashem, for coordinating the webinar. Before we conclude, I'd like to just remind everybody about the 618 Resource Center website that houses several assessment-related guides and tools. These can be found in the Measuring Implementation Progress folders under the General Tools for Medicaid, Public Health, and MCOs. In particular, we wanted to highlight a resource on monitoring progress and outcomes in the 618 initiative. This resource, which was co-developed by CHCS and SHADAG in 2018, includes a lot of great information on assessment relevant to the 618 initiative, including key implementation and impact measures states could consider in their assessments, as well as important actions for measuring progress. If you do have any questions or would like further information related to the webinar or the 618 initiative, please feel free to contact me. And then I'd just like to conclude by saying thank you again for participating in the webinar. Please take a few moments after the webinar to complete the evaluation survey, as your responses really help us to develop the most effective and useful learning opportunities. Thank you again for joining, and have a great afternoon.